This episode is sponsored by Circle and Bloom. Circle and Bloom has created an amazing offer for the Fertility Friday community. Make sure to head over to circlebloom.com/fertilityfriday to get your free relaxation program. And don't forget to enter the coupon code Fertility Friday at checkout to get 20% off of anything you buy. This is the Fertility Friday podcast, episode number 109. Welcome to the 109th episode of the Fertility Friday podcast. Thank you for joining me today. I'm Lisa from fertilityfriday.com, and this is your source for information about the fertility awareness method and all things fertility. Before I jump into today's interview, I just wanted to take a moment and let you know about my new group programs that are coming out in January. I recently completed my 10-week group program that I had going on since August. We started in mid-August. And it was just an amazing experience. So I was working with a small group of women. We met every single week. And not only did we delve into fertility awareness charting and really get a handle on what all the mucus stuff means and how to sort it all out, we also really started to get a handle on what's happening. What are the underlying factors that are contributing to cycle irregularities? And so it was just my complete privilege and honor to work with such an amazing group of women and to see how they were supporting each other and there for each other. So let me tell you, there's just something really powerful about working in a group. And I know that firsthand because that's how I learned to chart as well. And so that's why I'm so passionate about creating that experience and opportunity for you. And I'd also like to share with you what one of my clients recently said about her experience.
Yeah. This is a really interesting time to be answering that question. I think I would have always been very complimentary and would highly recommend it. But after coming recently from a trip for my very first time to go see a fertility clinic and recognizing the just stark disconnection between the mental, emotional, and physical, that they really treat you like, here's what you're supposed to do. Here's the boxes. They don't ask any questions. They don't allow you to be an active participant in the most intimate part of your life. I really can't think of anything that's like really more intimate. And so it's like I came back from that and I like signed up immediately for your alumni group because I'm now used to, from working with you, being treated with a certain respect and being able to be an active participant and ask questions. And I truly feel like you want me to understand. You're not just blanketly, throwing out this information and hoping it lands somewhere. You really want me to understand. And I think that's just so critical because, like I said, this is the most intimate, I think, part of our lives and important. And so I would definitely say at least start off with the group session. Not only will you get to work with somebody who has a breadth of knowledge that she really wants to share with you, but also you'll meet other women who are walking the same path. And that in and of itself, just to not feel alone, is so valuable.
So make sure to head over to fertilityfriday.com/group program for more information. Before we delve into today's interview, I'd like to take a moment to thank my sponsor. Today's episode is sponsored by Circle and Bloom. As many of my longtime listeners will know, I have spent a lot of time talking about stress and the negative ways that it impacts the menstrual cycle. And I've also spent a lot of time on the show talking about practical ways to manage stress. In episode 93 of the podcast, I interviewed Joanne Verkuylen, who's the CEO and founder of Circle and Bloom. And in that episode, we spoke about the science-backed evidence behind visualization as a stress reduction tool. Circle and Bloom has developed several programs specifically for women who are trying to conceive. Their natural cycle fertility program, for example, takes you through a 28-day cycle. This program has 28 different visualizations that are targeted and talk about exactly what's happening in your body at the different parts of your cycle. Now, as most of my listeners know, all women do not have a 28-day cycle. Most women actually do not. But the benefits of charting your cycle is that you do know exactly what phase of your cycle that you're in. And with this program, you can target the visualization based on exactly what's happening in your body at that time. And as a special gift to Fertility Friday podcast listeners, Circle and Bloom has offered a 20% discount when you purchase one of their programs. So head over to circlebloom.com circlebloom.com/Fertility Friday. circlebloom.com/Fertility Friday. Circle Bloom is one word. And make sure to use the discount code Fertility Friday, again, one word, at checkout to redeem your 20% discount. Now let's jump into today's interview. And today I'm very excited to welcome my guest, Dr. Marjorie Dixon, to the show. Dr. Dixon is a graduate of the McGill University School of Medicine. Her initial postgraduate training was at the University of Toronto in obstetrics and gynecology. Her passion for reproductive medicine continued during her postgraduate training, where she specialized in reproductive endocrinology and infertility at the University of Vermont. Dr. Dixon is an assistant professor at the University of Toronto in the Department of Obstetrics and Gynecology at Sunnybrook Health Science Centre. That's a real mouthful.
Yeah. Sunnybrook Health Sciences Centre.
I know. She also speaks both nationally and internationally at conferences in her field of reproductive endocrinology and infertility. And I had the pleasure of meeting Dr. Dixon recently at the grand opening of her new clinic here in Toronto, Inova Fertility. So on air, I just want to congratulate you. The clinic is amazing. It's beautiful.
Well, thank you so much.
You're welcome. And it was really interesting for me, as I was saying in our pre-chat, that I got to meet you in this kind of moment in your career where everything kind of came together and you were able to open your new clinic. So it was a really interesting way to actually meet you.
Yes, I know. Well, they introduced me and I was like, oh, I know who you are. Yeah, thank you so much for coming. It was a big night for all of us, and we feel for the women of Ontario and the infertile or people seeking to grow their families in Ontario, because we're in this newer catchment area. There's no full service center in North York, and now people don't have to go anywhere else to have their IVF. They don't have to do all the investigating and then go downtown and meet new people and try. It's all under one roof. It's really from a woman's perspective for the patients, and it's going well. So it's like if you build it, they will come. That kind of field of dreams thing. It's real. Right?
Well, that's a great place to start to kind of orient the audience to what you do. I know in today's show we're going to be talking about aging and fertility and IVF and all those different types of things, but maybe you can share your vision for the Inova Fertility Center. It was really interesting as well because I got to speak with some of your friends, and they made comments like, "Oh my goodness, that's so Marjorie," when they were looking at the decor and the design, and also kind of some of it's seriously, I picked up all the stuff because even in some of the locations where the patients have to sit down, you had, places where they could plug in their phones and all these really thoughtful things to try to make your patients more comfortable. So I'd just like to hear about the vision that you have for your new clinic.
Well, so it was one for patient care to be from a patient's perspective, because we are physicians and we are caregivers, and I work with a multidisciplinary team, so it's not just me. It is with our nurses, with our social workers, with our embryologists, with many of the people who work in Inova having had their own personal experiences with infertility. And so many of us have a different perspective because we understand the medical side and the necessity for some of the routine things that we have to do. You go in, you sign in, you get your bloods taken, you do an ultrasound, you wait to see the physician or you talk to a nurse, and then you know how many days you come back in and you start it all over again. And then when you're ready, you either have your insemination or your IVF procedure or whatnot. It becomes it wears on people. And there's no real other way to get the information that's required in order to diagnose, manage, and then treat for infertility and or issues of women's health, or people who seek to grow their families through assisted reproduction. So it's how do we make that experience the most manageable possible? And so we started off having people sit in the wait room. What is the experience from start to finish? What is the language we use in our interactions with our patients? What are some of the things that we need to be sensitive to, even in the language of how we deal with patients? Because, people are taking hormones and people are tired. They're worried about being late for work. Like, considering all of the other factors, apart from the fertility diagnosis, which is often, for some people, even debilitating. It's a burden and difficult. People don't want to have to see a fertility specialist. They want, to be able to have their families through the traditional way of having intercourse, or, through love. And they feel like having to put it into a medical environment kind of makes it more sterile and dehumanizes them to a point. And the plan was, okay, so even though patients have to go through this, is there a way to make the experience more palatable? Is there a way to make the experience calmer? And so that when you go on into your frenetic pace of life and you go on to work or to home or to care for your family or whatever it is that you do on a daily basis, you are not feeling in the first minutes of your day where you have to go through the processes of your workup or diagnosis or management, fertility care, that it's in a nice environment, that it's calm, that to look around is pleasant, that the people who are speaking with you are pleasant, that they understand your perspective, and that they thought about you, and not just about you, but you and your partner, and maybe you and the variety of conformations of your family. Maybe you have a gestational surrogate and an egg donor. Maybe you have a sister who is being your surrogate. Maybe you have your mother and grandmother who want to be part of your journey because they know that you don't have a partner, but they want to assist you financially somehow, so they want to be part of it. Is there a way to accommodate everybody in every circumstance, regardless of their family configuration, sexual orientation or identity, of religious background? Are we thinking of all of those things too, the sensitivities of those situations, just so that the experience will be more palatable and manageable? Mm-hmm. So that, and then also to have everything under one roof, because there was a concentration of fertility clinics downtown, and also in the north of the city there are a few, and there was nothing kind of in the Midtown to North York area. And much as we were there as a fertility monitoring center previously, there was no place for the IVF procedures to happen. And traveling, and anybody can attest to the fact that, wow, the traffic in and around Toronto is stressful in and of itself, but then going to another place, meeting a new crew of caregivers is anxiety provoking. And when you're trying to keep someone calm and centered and helping them in all of the aspects of their health and wellness to be balanced as they go through this fertility journey, the transit, traffic, parking, reorganizing yourself, and refamiliarizing yourself with your surroundings was not great. So, once we became busy enough, it became clear that, there is this need in this catchment area. Let us do it right. Let us do it right from start to finish. Let us make the technology the best that there is, but let's also make the experience the best that it can be, and all in one spot. And that's Inova Fertility. Mm-hmm.
Well, and it was really interesting to be part of it, and also to see the community. I'm not originally from Toronto. I'm actually from Alberta, so I grew up near Edmonton. And Toronto seems like such the big city, but then the more time I spend here, it's a big city, but then the communities within it are fairly small. And so, I guess one of the things that I talk about on the podcast a lot, the listeners have a variety of experiences and work with a variety of practitioners. So some are working with medical doctors, some are working with naturopathic doctors, acupuncturists. And so I guess one of the aspects of the work that you do is that you really work with a lot of different health professionals. Maybe you could talk about that a little bit and how you integrate that into what you do.
Yes. So I think that not just from the perspective of understanding our subspecialty has there been more scientific evidence that all of the variety of caregivers are all critical in their own way to the management of patients through their fertility journeys. And even in our governing bodies or the places that we go where we have our annual meetings, to the Canadian Fertility and Andrology Society or to the American Society of Reproductive Medicine, there are a variety of subgroups that each play their own crucial role in the management of our patients. And we understand that women and couples dealing with fertility issues are complex, and it is important to have all of their needs addressed through the journey. There's the medical, then there is the emotional, so the psychosocial aspects of it. There is also the people who are trying to optimize their wellness and then also put themselves in a place of balance and healthfulness as they approach their fertility time. So that requires the expertise of a variety of people, and people who have strengths that maybe a medical a traditionally trained medical person does not have. And the newer generation of fertility specialists are very open to working with other medical practitioners, such as the naturopaths, traditional Chinese medicine practitioners, acupuncturists. We have a massage therapist who comes into our clinic that we provide for our patients into the weight room twice a month, just in order to give them, one, that surprise that this is the day where we have the massage therapist, and two, it's kind of nice to have a conversation, have your shoulders rubbed on, have someone care for you before you move into the frenetic pace of your day. And also to be able to make the woman and patients feel entirely cared for, and not just that they are going to be given medications or have procedures to conceive. And that's one thing that we are understanding more and more, that the woman as a whole in her place of wellness is critical to a healthful fertility journey and then pregnancy.
Mm-hmm. Well, one of the questions that I love to ask my guests, I typically ask it at the beginning. I'm really curious as to what drew you into this field. I mean, there's 1,000 things that you could have specialized in. Why was this your focus?
So I had always known that I wanted to be a doctor, and I thought I was going to be a cardiac surgeon until I was in high school in the 80s, and it was the 10th anniversary of Louise Brown's birth. And Louise Brown was the first IVF baby worldwide conceived in the UK, and she was celebrating her 10th birthday, and there was a spread in Time magazine. And I was during my library period at school, at my private girls' school, and I was captivated. It talked about the future of medicine, being in reproductive biology, and understanding the science behind it, and I couldn't put it down. So then I thought, this is what I want to do. And I went to my guidance counselor, and I still remember her, Tanya Gito, if she's listening. And I was like, so what do I need to do this? This is the kind of doctor I want to help people have families. I think it's the coolest thing ever. And she said, well, you know what? I know you have to go to medical school, but I have to figure out the rest and I'll get back to you. And she did. So she said, okay, so you need to go to medical school, and then you need to do a residency in obstetrics, and then you have to do a further subspecialty in reproductive endocrinology and infertility, and you might do some research. And I was like, I'm in. That's what I want to do. And so I embarked upon this journey to that end.
Wow.
And I was involved in research in endometriosis when I was in medical school. And so I started off at McGill. You said the story of my journey. But, again, the whole 2 steps forward, a step back. I wanted to do a program that allowed me to go through Princeton, but that didn't work. I ended up at McGill, but that was a blessing because I was in the fast track program to get to the end goal of subspecialty. So I ended up fully trained and young and finished and able to go into the universe and start building what would become my career in the subspecialty of reproductive endocrinology and infertility. But you have to have passion for this because it is there are deep pulls of emotion through this, and some days are exhilarating and other days are devastating. And for both, it's tough on the patients, and you see them go through it. And as your physician and caregiver, you're in it with them, and it can be very draining, and you have to really love what you do to be able to do this every day and to strive to be the best at doing this every day.
Mm-hmm. Yeah. Well, beyond the incredible years of school, and I love that you had kind of sought this out in high school, and when your guidance counselor told you how many years of school you had ahead of you, you were like, cool, done. What else?
Yeah. It's the Capricorn right there. Like, tell me how to do it. I'll work at it.
January, baby. That makes sense. January or late December?
December 27th.
All
yeah,
right.
2 days after Christmas. So
that makes sense.
It makes sense to all my friends who call me type A driven. Oh, yeah, it makes sense.
Well, with that in mind, I think that one of the things too, like no one ever thinks that they're going to have trouble having kids. Like it never comes to mind. So then when a woman finds herself in the doctor's office trying to figure this out, maybe you can share what is kind of the difference between your regular doctor and a fertility specialist, in a way that the listeners can really understand how they can get the support that they need?
So I think that there is a role for all all care providers in this. The first step in fertility is the awareness that it is an issue. And when we talk about it, we talk about 1 in 6 couples, or 15% of the population. That's a huge statistic of people who are touched by fertility and having difficulty conceiving. So there is a role that can be played in a preventive perspective, because it's education and knowledge being power. Because women are often surprised when they get to see me, and at the average age of women in my clinic is 37. So we're already considered of advanced maternal age after 35, right? So by the time I've seen women, I know physiologically that it's going to be more complex and more difficult to conceive. And I always think that we do such a good job of public education around contraception. I don't think that the medical field has done a good job of conception education and conception planning. I'm not saying that every woman needs to go out and have babies when she's 18 to 25 because that's the ideal time. But what I'm saying is, in as much as you get an education about contraception, it's important that you understand the limitations of reproductive biology and have just a fertility health check between the ages of 25 to 30. Just to know, are you healthy? Is your ovulatory pattern normal? Is it regular? Are your periods regular? Some women don't ever understand or have a good understanding of what's a normal period. We're so busy in the, keep calm and carry on and take care of the people around us and getting through life, and we're getting our degrees, and we're getting our first jobs, and we're buying our first homes, and we're in relationships, and planning travel, but not necessarily thinking about, okay, am I healthy from a fertility perspective? Most people are like, I don't think I'm ready for a kid now, so I don't really care about that stuff. I'll just keep on my contraception, and then when I'm ready, I'll come off of it. But it's important to understand that by the age of 30, women have depleted their ovaries of 90% of its eggs. That means that only 10% of the eggs that you had originated with are in existence in the average 30-year-old woman. The good news is that the 10% that is there is still of relatively good quality. There should be not that much difficulty in conceiving in the average woman. However, by the time you've reached the age of 40, women have depleted their ovaries of 97% of their eggs. 97. So that means that the 3% that remain are not many and are generally of poor quality. It is not that women can't conceive after 40, but the women that conceive after 40 are exceptional. And because we see it in the mainstream press and the lay press and people talking about, I had an aunt who conceived when she was 43, so I should be okay. You have to understand the statistics. And even with all of the things and the expertise and the interventions and the science, the reproductive specialists can only work with your own eggs well until the age of 40. And then with challenge up until the age of 43. And then after that, the likelihood of pregnancy per cycle, even with the highest level of assisted reproduction with your own eggs, is less than 1%. So these statistics are shocking to most women by the time I see them. And often by the time I see them, I feel like I wish that we had done a better job. And so when you were between 25 and 28, your nurse practitioner in university or your family doctor, your primary care provider, nurse practitioner, wherever you were, someone said, have you thought about having a family, or if you even want a family? And if you've thought about it, have you thought about how many children you want? If you only want one child, then, you don't have to get too anxious about not being able to work yourself up and be able to do it. But some women are fairly convicted. Oh, no, I want 3 or 4 children. When you come to a fertility specialist at age 37 or 38 wanting 3 or 4 children, the likelihood of that happening is slim without some careful planning, right?
I think those are, and I think those are really, they're jarring statistics for someone who's hearing them for the first time. So just the other day, I was talking to my husband about our interview and, some of the questions I wanted to ask. And he was like, what about Janet Jackson? Because I don't even know how old she is. And she's, isn't
50.
She almost, and she's pregnant. And I feel like these are the things that kind of make us as women kind of think, well, right, if she can do it, I can do it. Maybe you could get struck that.
Yeah.
A little bit.
You're right, Jackson. I mean, we're part of the Rhythm Nation, man. We could do the impossible. I remember during the 90s, everybody listened. Every year she'd have a hit album. Like, she is what we equate with success. She's 50 having a baby. And we have to understand, unless, and I'm not her physician, so I have no way of really knowing, but the likelihood of her being pregnant with her own age at this age is impossible. She's magic, right? But if she had frozen her eggs, maybe successively over a 10-year period, I mean, Hollywood allows people through their ability financially to access things, to do many things that most people can't do. So who knows what she's done in the past. But if we think, if she did all of this in the past 2 years, the real only way is through embryo donation or egg donation, because our ovaries don't make eggs. Even though we get our periods, it's ironic. You can have periods into your 50s. The average age of menopause is 51. It doesn't mean that what you're ovulating will be a fertilizable quality or will make you a healthy baby. Many women do manage to conceive, 46, 47, it's impressive, but they inevitably miscarry. Or they have babies that have genetic abnormalities. The rates of Down syndrome and other genetic problems like trisomy 13 and 18 increase significantly after age 35 and then 40. So that's why we also recommend, if anybody does conceive after that time, that they either have pre-implantation genetic screening, a way of testing what the embryos look like genetically before you transfer them, or that you do an amniocentesis once you are pregnant to know what the health of the pregnancy is as well. Mm-hmm. So,
well, I'd love
Janet Jackson gives us hope. So a uterus is like, this is how I explain to patients, a uterus is like a condominium. Sometimes it needs a renovation, and it's a garden that you can fertilize with estrogen and progesterone and make it hormonally an environment that can accommodate a pregnancy. But the tenant matters. So the eggs needs to come from someone who is still in their reproductive phases and still in a good reproductive age span. And I mean, when we think about egg donation, we can take a menopausal uterus and get egg donors who are less than the age of 30 ideally, use their eggs, combine them with sperm, create an embryo and transfer it back into postmenopausal uterus after appropriate hormonal priming, and that person can carry a baby healthfully.
That's interesting.
Yeah, it's just to drive home the point that the uterus you can organize to accommodate a pregnancy, but the pregnancy will only be healthy based on the quality of the eggs. And after the age of 43, the likelihood of putting out healthy eggs becomes much less. It's not impossible, but it's much less likely between 43 and 45. And then we don't even offer IVF with your own eggs after 45 years of age.
Well, it's really, if any of the listeners want to kind of learn more about egg donation, I did an interview a little while back with Heidi Hayes from Donor Egg Bank USA. And it was a really interesting, as you can imagine, podcast episode, because she was talking about kind of the complexities of egg donation. She went through the criteria that they use to determine a donor. And so, yeah, she mentioned they wouldn't accept a donor over 30, but there was all of these other things, this list of, to try to to try to make it so that you're more likely to conceive. But then when you think about it in reverse, when you are entering the clinic at the age of 40, like, it really calls into question our understanding of fertility. We see women looking so young and vibrant well into their 50s now. And so we have this kind of like, we're looking youthful, but it's not matching up with our fertility and our biology.
Exactly. And this is what I get. Often people will be a little frustrated with me or upset with me for saying, but I think that the frustration comes from a place of not understanding that I'm just trying to be clear in the communication, that we haven't managed to change the evolution of the ovary. Our ovarian lifespans are limited. Physiologically, we ideally are made to conceive between the ages of 15 to 21 or 25, right? Mm-hmm. And then after that, there is a depletion of the number of eggs. It accelerates after 30 and then after 35. the reduction in the number of eggs through a process called apoptosis, so programmed cell death. And then the quality of the eggs is less because they've been on the shelf longer. And so much as on the outside, we can manage our health, we exercise. And this I still encourage people to do when they come to me after 40. I will say, you will be in the best place to conceive if you eat a low glycemic index diet and you are exercising 5 days a week, 30 minutes is what is good. Blood flow to your organs means blood flow to your ovaries and uterus. That's good for you. And get good amounts of sleep. You're more likely to ovulate after midnight. So, get good amounts of sleep, get yourself into a good rhythm so that if you are going to conceive, you are in an ideal place. Mm-hmm. However, your likelihood of conceiving is much less than it would be if you were here at 30. And that's just the truth. And then often I'll tell people they eat organically and they exercise and they don't smoke and they don't drink. And all of those things are ideal for conceiving, but it cannot reverse the ovarian aging process. And in fact, in my field, much of the research is looking at how can we turn back the hands of time in the eggs? And how can we improve egg quality? And how can we improve implantation? And we're also understanding a lot more about the role that genetics plays in all of this. And how can we modify gene transcriptions to turn off the menopausal genes? How can we look at the genes in the lining of the uterus so that we can understand which endometriomes are more likely to hold on to a pregnancy? How can the behaviors that we have modify our recruitment of eggs, the way that we get eggs out for ovulation, or the way we pick eggs for IVF, such that we'll be able to identify and modulate the quality of the eggs that we get? But that's still to come. We have not reached that place yet. We're limited by our biology still.
Well, and so there's no woman out there that ever anticipates that she'll have fertility challenges, but I haven't met a woman who doesn't believe that IVF will work on the first try. You know what I mean? Like, I've never met a woman who is ready to do IVF and she's paid her, I don't know, 12 to 25 grand. Like, I really don't know how much it costs. It's somewhere in there. I don't know if you could tell me. Yeah. But I've never met a woman who doesn't think it will happen on the first try. Maybe you can share with us the stats and kind of how you talk about this reality with your patients.
So how I broach it with patients is that IVF is truly designed to work in cycles of 3. That's the truth. And if you look at any of the larger databases where they have, thousands of patients that they put into a data bank based on their age and the presentation for their infertility. And they also use their BMI, so their height and their weight. So they're able to have very specific statistics for the reason for your infertility. Sometimes it's endometriosis, sometimes it's tubal factor, sometimes it's male factor, and then combine that along with your body mass index, which is also it helps to predict your success or failure with IVF. And then you get a statistical likelihood of pregnancy per cycle. So when someone comes to me, it's very individualized guesstimates of their likelihood of pregnancy per cycle, but the strongest predictor of this is age. So I will say to someone who is age 35 or less that their likelihood of pregnancy per cycle is in the range of, in our hands, 55% per cycle. But then as you get older, it diminishes. So by the time you've reached the age of 40, your likelihood of pregnancy per cycle with in vitro fertilization for all comers is about 30%, which is very different. And then by the time you've reached the age of 43, it's less than 10%. And then by the time you reach the age of 45, it's less than 1%. So age is a very important factor in weighing. It's probably the most important factor in the female circumstance of the ability to conceive per cycle with assisted reproductive technologies in the form of IVF. Go ahead.
Sorry, just referencing what we were talking about before. So that's with her own eggs and based on the age of her own eggs. And then the percentages, these are of pregnancy, and then the live
pregnancy per cycle. They're even lower of take-home baby, right?
Yeah.
So, and that I also talk about the difference between that. And you have to be careful when you're trying to, compare clinics and look at statistics and what people put on their websites. you really have to have a conversation with the physician about the experience in that center, and then the difference between a clinical pregnancy and a take-home baby. And so, for example, patients who come to me and they say after age 40, I want to start with inseminations. And I say, well, I have to be clear with you that after age 40, no matter what we use for ovulation induction, so the way that we grow eggs, sometimes we give pills, sometimes we give injectables, sometimes we do a combination of both, sometimes we use something called Lupron. No matter how we grow the eggs in someone after 40, if we're thinking about doing just inseminations, the take-home baby rate is less than 5%.
Wow, over 40.
Yeah, over 40, less than 5%.
Wow.
So, and these are enlarged, I know, right? And so when I explain that to the person, they're like, wait, break it down again. What are you saying? I'm saying we can do inseminations, and it can work. But even if you do conceive, your likelihood of taking home a live baby is less than 5%. So that is why when patients come to me in or around the age of 40, 38, 39, 40, it's not that I say don't do inseminations, but I'll say we'll do inseminations maybe for 1 or 2 cycles if you really feel that you must, because the job of me is to bring you a family, and I want to give you the most effective way of reaching your goal. And that would be at that stage through in vitro. But I mean, it's interesting that you said to me, I'm going back to the original question, and you said to me that what you haven't met a woman who thinks that she's not going to get pregnant in her first IVF cycle. And I don't necessarily see that. I mean, I do see some women who are optimistic, but by the time I guess women have reached me, they maybe are a little more well-versed in assisted reproductive technologies. And, especially with the province of Ontario now funding 1 cycle of IVF in certain clinics, that they know, well, I have access to 1 cycle, but I understand that, there might be a wait list, and I might wait to get my cycle, or I'll get my cycle and then I might do another cycle because I know that it doesn't always work on 1 cycle. So patients do come with a degree of knowledge about it not necessarily working in one. It often does now, and especially in the younger age groups. But and 1 cycle, I have to clarify as well, is 1 retrieval cycle. So 1 cycle of IVF meaning 1 stimulation, egg retrieval, embryo creation, and then whatever additional supernumerary embryos that are frozen is all part of 1 cycle. So you can have a baby from the fresh cycle and then have 3 other frozens and then come back in a year to have your frozen cycle. That's still considered the first cycle.
Okay.
And then whatever frozen embryos, so whatever embryos came from one time of stimulation of the ovaries and embryo creation is considered part of the same cycle. So sometimes patients will say, well, I had an IVF cycle and it didn't work. Well, have you completed all of the embryos from the cycle? No, but it didn't work that cycle. I said, well, you actually still have embryos from that cycle, so that cycle is not finished.
Yeah, that kind of changes how you look at it if you think about it that way. And
yeah,
I really like what you said about kind of the 3 cycle thing, because then it kind of shows that this is a process and not necessarily a one-off, to really get those expectations in a more realistic.
Yeah.
And maybe the comment that I made about women not necessarily expecting not to work is not from a scientific place. It's from more of a personal experience with friends and with listeners of the podcast. Because as we know, in the way that this whole kind of, the way that it's presented to women in a way, whether it's directly or indirectly, is that, well, don't worry if you have problems because IVF is always there to fix them. And it's kind of exactly what you're talking about with respect to that education around our age.
Yeah.
So
knowledge is power.
Yes.
Yeah. I really feel that if we do a better job of educating and getting this information out, then people will come in with the information and be more willing to hear you if you're saying something they didn't necessarily really expect to hear. Because if you're saying these are what the statistics are, and this technology exists not just for the last-ditch attempt, but as the best tool for certain circumstances at a variety of ages, then people are more open to okay, well, maybe I'm okay with IVF. Because what sometimes I find is that patients are, and you have to respect people's wishes and desires, right? Pregnancy is not something that you must have. And often people come in with this preconceived notion of, I want to do this more naturally than anything else. And so I don't want to take medications. I don't want to do IVF. And so we try, and then time goes by. And if it doesn't work, sometimes they change their minds. And then when they get there and we do the thing that we wanted to do initially, but they weren't ready for, and they get pregnant, they're like, oh, I wish I'd wrapped my head around this earlier. I thought it was bigger. Like, people sometimes imagine that IVF is a bigger process than it turns out to be. And then, of course, you have the converse. The people come in and say, I want to do IVF right away. And wow, that was more emotional than I thought it was going to be, or that was more medically taxing than I thought it was going to be. We're all different. Women are different, and we all come from our variety of experiences that form who we are. So it's really, you have to find a caregiver that it has the ability to communicate what's going on in a clear fashion, but also who is able to hear you and your needs for your approach to your healthcare as well. Mm-hmm. And so it's kind of an ebb and a flow through the process. And not every doctor is right for a certain patient, right? Like, some people like a more direct, kind of frank, blunt, do this and there's nothing else that you can do. And then other people are like, well, these are your options, and here are the 4, and you can do this, which might lead to this. Like, people need an analytical breakdown. It really depends on the patient, right?
Well, and I love the way that you kind of, like, obviously you meet the patient where they're at and kind of tailor the recommendations and the treatment based on what is right for that person, what is right based on their age, what is right, like giving them a really realistic picture, not just of one thing or another, but just based on all of those different factors.
Absolutely. And that's what we're learning, that, there are certain things that even, when I finished training like 15 years ago now, that we were talking about, the AMHs were not mainstay. The anti-Mullerian hormone assessment that is secreted by the granulosa cells, or some of the cells that are within the follicles that contain the egg. And we know that women who have lower AMHs don't respond as well to medications. Women who have higher AMHs may respond very briskly and be at risk of ovarian hyperstimulation syndrome, which is one of the complications that can happen during IVF. So it happens in 1 to 3% of patients. But we can actually use the combination of the anti-Mullerian hormone, their day 3 FSH, their antral follicle counts, their prior responses in their stimulation cycles. You have to tailor each individual's protocols to what you have as objective parameters on paper. It's really changed over the past 15 years. It used to be, if you're this age, that's your protocol. And if you're this age, that's the protocol. And if you're this age, that's the protocol. That's how we did it. Now we look at everything. And then we look, okay, there's this, and then your BMI. And then we look at the woman as a whole and say, well, in this BMI, I know your likelihood of pregnancy is really not high. And then furthermore, if your sugars aren't well controlled, your baby's at risk of having congenital anomalies. So I need your hemoglobin A1C to be here before we start any stimulation protocol. And then sometimes women feel like, are you kidding me? I'm older. I came here to get pregnant. And now you're finding things that you're going to give me. You want me to lose weight, or you want me to get myself into a more healthful sugar profile? Like, that's going to take me more time, and that frustrates me. But really, we are medical doctors first, and we have to look at the woman as a whole, and we want to do things safely and well. So everybody's an individual, and everybody's care needs to be tailored.
Mm-hmm. Well, and for the woman who is really skeptical and comes in with, I want all natural, I don't want any medication, I don't want IVF. I recently did an interview with Mary Wong, and it was a really powerful interview. And
I love Mary.
Yeah, I saw her the other day. We had lunch, and she told me to say hi. So hi.
Hi.
She'll love that I did it on air. But but so she was sharing her story, and especially coming from a traditional Chinese medicine perspective, being that that was her profession, not only her belief system, but her profession for 20 odd years, and then having to really open herself up to the not even just IVF, but IVF with donor eggs. I mean, maybe you could speak a little bit to that. For the, one of the things I try to do with the podcast is share different perspectives. And I sometimes look at things from kind of that completely non-medical, like metaphysical perspective, where I feel like motherhood is this metaphor for your loss of control. So if you're super type A and you want everything to happen a certain way, then I mean, it's almost like a practical joke, like not a nice one. It's a horrible one. It's like really, it's not. But I think you know what I'm getting at, because however it is that you want things, I mean, you're creating a human being, and human beings come with their own personalities, their own attitudes, and I feel like there's something greater going on there.
Yeah, it's interesting that you should say that, and I have this conversation at least once daily, where I say that one of the most disarming things about this whole thing is the loss of control. And you have to kind of reevaluate how you're going to approach this and how you're going to see it. If you want to be I'm going to let the medical professional, I'm going to trust this person, I'm going to ask the appropriate questions, but I'm going to go with what their recommendation is because I came to them because they're the expert. And then I have the other people who just can't. Like, it's almost like they want to grasp onto every possible last vestige of control to be able to say, well, I will feel comfortable if we do this test, and maybe we should do this test. And I read on the internet that there's this other test. And I say, I'm a medical professional in this field with this training, and my job is to help you to conceive, but also I don't want to do a whole bunch of tests that I don't think are worthwhile or indicated, even though they may make you calmer, because it's not serving a medical purpose to do all these additional tests and spend this extra money on these things that you don't necessarily need. And the ability for us as practitioners to appreciate that even within our subspecialties, there are things that are lacking. And I don't think that Western medicine does a good job of considering the woman's wellness and the woman's wholeness as well as it could. And working on a regular basis with holistic health care providers, allopathic medicine, naturopathic medicine, and Chinese medicine, and acupuncturists, you realize that there is good that comes to your patients that you can't put your finger on because it's not your realm of expertise. But wow, the patients come back to you in a completely different place. And then you can actually practice the medicine that you need to do with them in their right place. So there is something that is to be said about the marriage and the yin and the yang of the variety of approaches of Eastern and Western medicine. And Mary Wong, of all people, does a great job of, and in her new book, she has a new book, she puts it all together of the Eastern and Western medicine interplay and the critical roles that each of them play at a variety of points through the fertility journey. And she speaks her language and I speak my language, and we say the same thing from different perspectives, but it is just as critical to the well-being of our fertility patients. And I think that we really have to be able to appreciate that we aren't always in control of everything. We just aren't. Mm-hmm. And I can do the best medicine ever with the greatest technology and the cutting edge gold standard protocols and tailor everything to the individual. And still, I have to tell you, every day there's this little bit of magic that I can't explain, that I will have a patient who conceives, and I was not expecting, their embryos weren't good, the lining wasn't the best, and they have this miracle baby. And then you have the other patient where everything looks perfect and the lining's perfect and their embryos are perfect or their cycle's perfect and they don't conceive. So there is something about feeling that your total person is cared for in your fertility journey that can assist you with your overall success through the process.
Well, I really appreciate you sharing your perspective. And I love the way you broke it down and just described that marriage, essentially, and also affirming that need to have these different providers providing care to the woman. I mean, I think the comment that struck me was that, you know, you send the woman away and she comes back kind of different and more ready, meaning that whatever her needs were, may have been addressed in a different way by different care providers.
Exactly.
Yeah. And so that's something that I really encourage the listeners to kind of keep an open mind. I often use I love analogies and things like that. So I often use the analogy of a boardroom, and you have all of your care providers at the table, and each care provider has a specialty. And so you kind of need to give each one the floor and then take in what you need to take in and make the decision that's going to be best for you based on all of their perspectives.
Yeah, absolutely. Yeah, it's, we have our objective medical information and we have the evidence-based information, and that's what we draw from. And now there is more evidence about all of these other realms and subspecialties that are in healthcare providers. And we can't deny it anymore. The old school maybe denied it, but the newer school generation, we can't, because we see the evidence. And then furthermore, we see the benefit to our patients. And as more women are providing this care to other women, it's undeniable. So we got to go with the flow, and we want what's best for our patients overall. Not everyone will have success in their fertility journey, but we want the whole woman to feel cared for. And if this can further even improve her success through her fertility journey, well, that can just be a win-win.
Well, and I'd love to pick your brain a little bit before we get towards the end of the interview about some of those kind of cutting edge medical things that you alluded to, given that you're in the field of research, you're a professor. So I can't even imagine what's going on in your brain in the fertility section. But
what's going on in my brain? I sometimes I laugh because I call my children my new brain, because there's so much information in my brain that sometimes I'll just drop words. I have senior moments, and I rely on my kids to tell me what my schedules are. But the medical stuff, because we are continually, expanding our medical education and knowledge, and we go to these conferences and we listen to other researchers and also get from the literature the different and newer evidence for new procedures, new techniques, or what's going on from a genetics perspective. So the genetics and intracellular environment is something that has always fascinated me. And I was involved in, there was something looking at the energy within the cell and the mitochondria. And mitochondria are like the charged energy cells, or the batteries of all the cells of our body. And we know that there's a critical threshold of mitochondria that are required for proper fertilization, and then in order to propel the embryo to divide into even cells and to grow up to the blastocyst stage, which is 5 days after the fertilization process of sperm and egg. And if that critical threshold of mitochondria has not been achieved, then there is a much lower likelihood of blastocyst formation and healthful blastocyst creation. And so when we talked about egg health and how do we reverse egg aging, and what are people looking at from how do we transcribe genes and how do we change the mitochondrial environment, that's the stuff that is continually going in my brain. But I am primarily a clinician, so I rely on these collaborations with the scientists in the field. So the people at the University of Toronto or at the universities worldwide within divisions of reproductive endocrinology that are looking at what's the next and the newest and what is going to bring to our patients their dreams of family, because it always starts scientifically. And that will also be in, can you turn up or turn down genes I mentioned earlier for menopause, because there are novel menopause genes that exist and that people are now discovering. And is there a way that we can slow the turn on of those genes? Can we delay the onset of menopause from age 51? Now, would you really want to have your period any later or have the ability to modify that? But that is, if that can be determined, then that has the ability to also potentially reverse the aging of eggs. And recently also there was uterine transplantation, right?
Yeah,
so in the year 2014, and I believe it was the first week of October or the last week of September, a Danish group was actually successful in having a healthy baby boy born from a transplanted menopausal uterus into a young woman that did not have a uterus. So was able to use her eggs, because your ovaries and your uterus come from different places, and they transplanted this uterus to the person's blood vessels in her pelvis. And these blood vessels are blood vessels that men have too. So that opens it up to the potential. I know it sounds crazy, but it opens up to the potential for men to have transplanted uteruses and to carry a baby. Of course, it would be complicated. They would need anti-rejection medication. And it was a proof of principle because it was not just one baby. There was a series of babies that came from that. And now they have a trial on in the U.S. where they're doing that at the Cleveland Clinic with one of my doctors from Montreal. He's now there, Thomas Falcone from McGill University originally. So he's now working on uterine transplantation and how that can work. So, and the baby needs to be delivered by cesarean section. I know everybody's having a mental of how that would happen. Men won't be able to push the baby out of their penises. It would still have to be cut. But that's another possibility.
Wow.
And then, stem cells, they have mouse studies where they looked at pluripotent stem cells, and they were able to take cells that were not from the gonads, activate them, and make them grow into an egg cell line in mice that had no ability to have babies. Did little mini mouse IVF, and then put these into the uteruses of these blind mouse, and they actually had litters.
Wow.
So if you can transform stem cells into egg cells, then maybe you would never need to worry about your ovarian aging. Now, this is all in the research realm, so we're talking mice or primate models, or, well, except for the uterine transplantation, that was in humans, so that's been done. It just goes to show that, back in 1978, when they had that first IVF baby, and they had been trying for 10 years, by the way, to make the IVF baby thing work. And there was a race on between the UK and the US, and the UK won. And now in the lay press, there's been all of this stuff about the 3-person babies and mitochondrial disease eradication by being able to take the mitochondria from healthy eggs, transplant them into unhealthy mitochondria eggs, and make healthy babies that aren't afflicted, and their children don't end up having these debilitating mitochondrial-related diseases and dying at young ages. Medicine is so miraculous.
That's incredible. Because you're not even
you wonder what goes on in my head?
Yes, you're taking me down the rabbit hole. Thank you. Because we went from transferring the egg to transferring the mitochondria within the egg. That's wow. Yeah.
Yeah, it sounds, you're right, Alice in Wonderland, fantastical. But I hope that somewhere there's some young lady or young man listening that says, oh my gosh, that sounds fascinating. And who knows, maybe that's the spark and they will be the person. Maybe it's an IVF baby, maybe somewhere, or a baby that was conceived through insemination that then has this interest sparked, and then will go on to be that person to make that discovery or to participate in the research that gives us more information about egg health and about how to help women with the variety of diagnoses that they have with infertility to conceive and have their families.
Mm-hmm. Well, and you touched on something, and it was something I've read articles about this. So we talked a lot in our interview too, is about your eggs and how you have a certain number when we're born. We've always been told this, and then as we age, our ovarian reserve depletes. So we talked about that. But then some of the research that you alluded to would imply that we could grow new eggs.
Yes. So it's still in the experimental world. There is still there has been the discovery of what we call stem cells, but they're not actually pluripotent stem cells. They are predetermined to become egg cells, but they have not further developed. And they're located in the ovarian cortex. This is based on some of the research of Jonathan Tilley in the U.S. When I was a fellow, I remember when he first published this paper, no one believed him. And so we debated it, we talked about it, and can anybody recreate this? And then they did recreate it. And then they did some initial experiments, but they were able to grow, extract the mitochondria from them and use them to re-energize these egg cells. The potential is for these stem cells to then not ever need to be put into the ovarian cortex to grow, but they could be grown outside of the body, and a woman would never have to take fertility medication. And you could take these stem cells, grow them in culture, and then inject them with sperm in a petri dish, and then transfer embryos into a uterus, because they're predetermined to become egg cells. So if you can mature them in vitro, which would be called in vitro maturation, you could then fertilize them outside of the body and then put them back into a uterus without a woman ever having to take fertility medication.
Wow.
I know, right? Mind blown.
Totally. So let me just say it again so that I can make sure I have my head around it. So in this way, then a woman doesn't have to take any type of medication to kind of force the ovaries to spit out all the eggs.
Right, because these predetermined to become egg cells that get taken out of the outer part of the ovary can then be matured in vitro in a Petri dish to the point that they can then be fertilized in the Petri dish. And then that embryo can be transferred into a uterus. It hasn't been done yet. This is the future. This is the potential for the future. The discovery of these stem cells that exist on the other side, they've been used to obtain the mitochondria. That was the first augment baby. That was from the mitochondria that came from that, and the injection of the mitochondria from those stem cells into the woman's own egg cells. So that was her own mitochondria, so that added energy. That was the first principle that we talked about early on in the discussion. But the second principle, the potential application of that, would be if you could grow these eggs in vitro and without the need for gonadotropins into the woman's body, it would just be, okay, let's do this procedure. We'll take the part of the ovarian cortex, we'll extract these eggs, we'll mature them in a Petri dish, fertilize them in a Petri dish, and then transfer them into your uterus.
Wow. The implications are astounding there.
Astonishing. The drug companies are all like, stop laughing.
Yeah, no kidding.
Those are the potentials. And so science is amazing in as much as often theories that people say are almost heresy. That's crazy. That'll never happen. Listen, no one believed the first IVF baby would ever happen, and now millions of babies worldwide are born through IVF, right? So if we know how to conduct our science in a sound fashion and do our proper clinical trials and get our information and get our first scientific information and then apply it safely and get that information, we can then, the future is unbelievable for women. Maybe infertility will be eradicated. It sounds crazy, like, oh, really, medical diagnosis never existing. Who knows what's going to happen 2 generations from now or in a generation? We don't know.
Mm-hmm. Well, and you mentioned the augment baby. And so I actually grabbed something from your website. So it says, I'll just read it for the listeners, and then you can just explain what it means. But in April 2015, Dr. Dixon and her staff were happy to announce the arrival of a healthy baby boy named Zane. He has the distinction of being the first baby born in the world using augment treatment. And then it goes on to describe a little bit more of some of the things that you talked about. But what does that mean? I mean, that's amazing. First of all, congratulations. I mean, that's the first in the world. I mean, that means that's incredible. I can't even imagine what the implications are for your clinic, for your profession, for the dreams that you had when you were in high school and you wanted to be a doctor. I mean, that's incredible. So, yeah,
I think that the ideal of the science being applied to life and seeing healthy babies come from it is what we strive for, right? The scientific world applying to the clinical world. Zane is now, he was born on April 13th, 2015, so he's a year old, went to his first birthday party. He's a spitfire, smart, fantastic little boy. And his family had an initial IVF cycle that was, the embryos were not of very good quality and she didn't conceive. And then when I was working with Dr. Casper at a different clinic called T-Cart, he had the opportunity to start a few patients through what was available for the cytoplasmic mitochondrial transfer. And I understood the principle of it, but it would be the first, there were several groups that started at the same time. And I had never conceptualized that I would be the first, really. I was just, he's like, we have the ability to do this, and I can have 2 of your patients if you have to pick the right patients, in whom was someone who had failed the cycle of IVF and who was shown to have poor egg quality. And I found I had the right patients, so I said, well, let's see. And then we had to have a discussion and have them consented, etc. And then we went forward for another cycle of IVF. So we did the surgery and then her IVF cycle. And her embryo quality the second time around was night and day from what it had been, really. And, we have all of we actually always document everything. So we have the pictures of the embryos before and after to tell the tale of the successes of what had happened. And we'll never entirely know if it was that the patient had a different kind of protocol, or after we had done the process, was it really the cytoplasmic transfer of the mitochondria that made the difference in what her embryo quality was? But she made beautiful embryos, and we transferred, and they're Zane. Mm-hmm. And so it is not for everyone, and it really requires us to have more information and data about how the impacts, the long-term impacts will have on the greater fertility world. So we really want to be sure that when we're looking at new applications, that we approach them and have a proper scientific process and get all of the data that we need to be able to say. So when patients are asking us, does this apply to me? Does this apply to me? Then you have to say, well, with this information in your age group, with this presentation, with this kinds of eggs and this type of infertility diagnosis, that this is applicable to, or it's not. And so there's so much exciting things happening and going on, and not just in North America, but all worldwide, and in the UK and through Europe. And so, bringing all of the scientific minds together at our annual meetings, and having the internet as well, and having our variety of scientific journals that are so accessible to us now, whereas before you'd have to go to a reference library and find the reference. I mean, when I talk to the medical students, they are like, oh, you can just get it online. I'm like, oh, you don't know. We used to have to go to the medical libraries and go into all of the various stacks and get out the landmark articles and go back to them and reference all the references that they had. It's amazing to see where we have come from and where we are headed. And much as the future sounds like it's science fiction, I think we have to remember and challenge ourselves every day to say that, well, way back when the idea of taking egg cells and sperm cells and putting them together to make babies, or for women who had blocked tubes to be able to overcome fertility, or for women with bad endometriosis to be able to conceive, or for women with ovarian failure to be able to conceive through egg donation or gestational surrogacy, or for individual single men coming to have coverage in the province of Ontario with assistance to grow their families. All of these, we are continually taking steps. The Ministry of Health providing cycles of funding IVF for everyone, all comers. So it's not always a socioeconomic discussion. We're making giant strides forward in our field, and both scientifically and societally. And I wonder what it's going to be when I come to my, 30 years down the road, at the end of my career, to be able to say this is the spectrum that I saw through my lifetime in reproductive endocrinology, and what the children that I helped bring into this place have become, and what they've contributed and what they're doing. It's that it's such a privilege to be in the place that I am right now, and it's exciting to be part of this next step moving forward. It's a blessing. It really is.
Mm-hmm. I think everyone's going to leave this conversation feeling really inspired. And so we've covered so much ground. What is one thing that you would want the listeners to take from our conversation today?
I really think that knowledge is power. Educate yourself, ask the questions. If you want to see someone to have a conversation, make sure that you find someone who can refer you to a subspecialist who can actually talk the details of what you need answered. And don't ever be told that you don't need to talk to anybody. That frustrates me when someone tries to get the knowledge and then they can't access a specialist. We are here. Do your investigating, find the provider that's right for you, and get your questions answered so that you can make an educated decision about how you want to approach your family building.
Mm-hmm. If there was one myth about fertility that you could completely eradicate, what would it be?
Looking good on the outside makes your ovaries good on the inside.
I love that. You're the first one who said that.
Really?
Yeah. And
I don't know what anybody else said now. I feel like maybe I should have said something else.
No, that's really good. That's really good, though, because I've heard them all, right?
Yes, okay.
And so last question of the day, what advice, if any, would you give to a couple or a woman who's struggling to conceive?
I think that it is, believe that it is possible, because the options are limitless. It's just you have to pick what's right for you. Yeah. Often people will think that there is a limit in what they can do, and they're surprised when I review all of the potential options. So don't sell yourself short. If you're interested, come talk and we'll figure something out, or not, right?
Mm-hmm.
But don't sell yourself short. Go talk, figure it out.
Well, Dr. Dixon, that was wonderful. It was such a pleasure to be able to chat with you and to pick your brain and go down the rabbit hole a little bit and find out some of the research, some of the things that are going on in the fertility world. It was just a real pleasure and a treat to have you on the show. So thank you so much for being here.
Thank you so much for having me. I don't think I've ever had all of that in an interview. I apologize if I babbled, but it really is. I think that to be able to have these conversations and to be able to provide the information to the public at large about what it is that we do and what it is that our patients struggle with, increasing awareness and also increasing knowledge to the greater public, I think is primordial.
Mm-hmm. And so for the listeners then who are lucky enough to kind of live in Canada or in Toronto in particular, maybe you can tell the listeners where they can go to find out more information, and also for the local listeners, if they're like, my goodness, she needs to be my doctor, holy cow.
Well, the web is one of those places that no matter where you are, you don't have to be local or distant. You can go to the web, and we have a resource page at Anova. So it's www.anovafertility.com. Gosh, I hope I got that right. I'm not the worst. I'm not a great promotion of myself.
We'll have the link too.
If you watch so I'm on social media, on Twitter, on Instagram, and on the web. And if you just watch that, we're going to be having an IVF information session in December at some point. So that will be open to whoever. It's not just to our patients. So if you watch our social media feeds, there'll be information about that. And then we always put stuff up on our website anyway. And then, reliable resources about infertility would be not just listed on our website, but also at the American Society for Reproductive Medicine. I believe they're .org, and then the Canadian Fertility and Andrology Society. Yeah, ASRM is .org, and the CFAS, Canadian Fertility and Andrology Society.ca. There are, patient resources, and you can go into those places. And then even some research and information if you're curious about this field, if this piques your scientific brain and you want to find out what's going on, you can go there and look as well. And the publications are also listed there. Reliable sources, though. Don't just search Dr. Google. Good grief. Sometimes it gets bad.
Yes, Dr. Google. Yeah. Anyone can contribute to Dr. Google.
Exactly. Yeah.
Oh, well, thank you so much. It was such a pleasure having you.
Well, thanks for having me. Anytime.
Thank you for listening. If you enjoyed today's show, please share it with a friend. You'll find the show notes page for today's episode at fertilityfriday.com/109. I hope that you enjoyed my interview today with Dr. Dixon. It was such a treat to have the opportunity to talk with her and to really delve into aging and fertility as well as reproductive technologies. I really like getting perspectives from different practitioners, and it was just especially interesting to have a perspective from a fertility specialist. And I think that it's really important to remember that although there's a ton of things that you can do to improve your fertility naturally and to understand your cycles better and to time sex accurately, there's always situations where women do need reproductive technologies and assisted reproductive technologies. And so I think it's really important to have a good understanding of that, as well as how combining natural methodologies and natural treatments with artificial reproductive technology can just be so much more beneficial and effective for women. And so that's one of the things that I love about Dr. Dixon's practice, that she really does encourage her patients to seek whatever support that they are comfortable with. And she really works collaboratively with other practitioners, whether it's naturopaths or traditional Chinese medicine doctors or what have you. But she really works collaboratively with other health professionals in her practice. And ultimately, the goal is to provide her patients with the best experience possible. And of course, to support her patients in conceiving. And so if you enjoyed today's interview, please stop by the show notes page and leave a comment, which you'll find at fertilityfriday.com/109. If you've been enjoying the podcast, please look for it on iTunes and leave a 5-star review so that more people can find it. I really appreciate all of you for taking the time to leave reviews. There are so many positive reviews on the page, and it really does make a difference. I've been seeing a huge difference in terms of the number of downloads. And I also appreciate all of you for sharing the podcast, and for whether it's sharing an episode with your friend or tagging your friends on social media or however you're sharing it. I really do appreciate it. And I just want to mention that November is my birthday month. So I've declared the whole month to be my birthday. And so I would absolutely love it if you would, as a special birthday gift to me, share the podcast episode in whatever channels. So whether that's sharing it on social media, if you pick an episode that you think would be helpful to somebody, or an episode that was your favorite, if you were to share that. Or I know some of you have your own platforms and blogs and even podcasts. And so if you were to share about the show or your favorite episode, I would appreciate that so much. And if you do share any episodes, make sure to tag me on social media. So on Twitter, I'm at Fertile Friday. On Instagram, I'm at Fertility Friday. On Facebook, I'm Fertility Friday. It's facebook.com/Fertility Fridays with an S. And also, if you haven't had a chance to hop into the private Facebook community that I have for the Fertility Friday listeners, just head over to fertilityfriday.com/community to join the group. So I'd love to have you in there. And of course, I just want to mention that my January groups are filling up. And so there are still a few spots available. I'm doing 2 different groups this time. So I have one group specifically for women who are trying to conceive, and I'm hosting another group specifically for women who are using this method right now for birth control, and they just really want support in getting all the rules down and really getting clear on which days are fertile, which days aren't. And so the birth control group is filling up pretty quick. And also there's only a few spots left in the group of women who are trying to conceive or planning to conceive in the future. So if you would like to be a part of my January 2017 groups, I would really encourage you to head over to the group program page, which you'll find at fertilityfriday.com/group program. And make sure to apply so that we can reserve your spot. Because once the groups fill up, then it's closed, and I only offer the group programs a couple times a year. So if you would like to be part of that, I would really encourage you to hop on that sooner rather than later, before the spots run out. And so I just want to thank you so much for hanging out with me today. I really appreciate all of you for taking the time to tune into the podcast and for letting me be part of your day. And whether you're commuting to work, I know some of you take me to work in the mornings, or whether you're out for a run or doing dishes or laundry or housework, I'm listening to podcasts usually when I'm doing things around the house. And so thank you so much. And as always, until next time, be well and happy charting.